We start with these is that the advice I'm giving you tonight does not replace clinical judgment. And it's important to understand that guidelines are just that. Guidelines are in fact guidelines. They're not the law. They actually assist you in practice. And it's a very important thing to discriminate against about what a guideline is versus what is clinical acumen, because nothing replaces clinical judgment. You have the patient in front of you. I'm going to introduce you to Pete, and I'll read from the notes of Pete's story. And Peter's basically a case that we've adapted for this presentation, but I'm sure that you all know this man. He was found unconscious on the floor of his beloved angling club at 10 a.m. on a Sunday morning, and despite attempts to resuscitate Peter, he was pronounced dead at 66 years of age. Now, Peter was survived by a wife of 40 years, 3 adult children, his first grandchild. The family and friends were quite shocked because he was an outdoor-loving and an active man, and that he died so soon. And his much-anticipated retirement from his landscaping business, and he was just starting to do the things that he loved. A post-mortem, not of his body, but of the years leading up to the death, reveal a number of things. What actually killed Peter? This did not come unannounced, but rather unnoticed and unchecked. A year before, he'd reluctantly gone to his GP at the urging of his wife, very common story, concerned about her husband's arthritis and diminishing dexterity. At the time, he attended his GP's blood pressure was 135, systolic. He was prescribed a non-steroidal anti-inflammatory for his arthritis. The GP gave him a pathology request for fasting glucose measure and lipid profile, and the returned results showed nothing alarming. On the return visit, the GP explained to Pete his total cholesterol had crept from 5.7 to 6. His high-density lipoproteins, his HDLs, of 1.5 was actually unchanged, and his fasting blood sugar test was well within normal limits. Finishing the consult, Pete and the GP discussed the fishing season ahead, and he promised to give away the smokes. At the time of his death, Pete had cut down his smoking to 3 a day. Now, his story is extremely common, and one Australian dies as a result of cardiovascular disease every 12 minutes. And in 2011, there were just under 46,000 deaths attributed to cardiovascular disease. And that's a lot of families that are losing someone like Peter. Where cardiovascular death doesn't ensue from the disease, you're left with someone who has residual life-disabling condition. Unfortunately, cardiovascular disease is the second biggest contributor to the burden of disease in Australia and the most expensive. We're looking at around $6 billion a year annually on just direct hospital costs. The Australian Health Survey is a survey of Australians that was conducted with the Australian Bureau of Statistics and the Heart Foundation's support, 2011 to 2013, and I'll share with you some alarming stats that have come out of this. 2.37 million Australians, that is 1 in 3 over 45, had high blood pressure. That 3.5 million over 45 actually had high cholesterol. 800,000 Australians over 45 had diabetes, and 1 in 11 of this group had only had a HbA1c. So we're still not getting it with diabetes. That's phenomenal. 1 in 7 still smoke, and 5.14 million over 45 were either overweight or obese. And one of the alarming parts that came out of this was one of the silent ones is kidney disease. 1 in 10 from the testing, and most of those didn't know they had renal impairment as it stands. So we're going to talk about estimating risk, because there's been a lot written about how do I do this, what is it, and in fact, can we in fact look at this? Peter, as a case, presented really quite healthily. When you looked at the blood pressure results I gave and the cholesterol results, anyone really have actually put him on any medication with those results? The answer is, well, no, not really. I mean, his risk factors individually, such as moderately raised blood pressure, moderately raised cholesterol level, he smoked, and we all do that pretty well by saying stop, and it sounds like he was making goes at it. So other than that, we would have said on an individual basis, he's pretty healthy. Now this is from the NVDPA, the National Vascular Disease Prevention Alliance, which is stroke, diabetes, kidney and ourselves as Heart Foundation. We have a website which at the bottom here has our calculator on there for you, which you can bring up, you can use, you can in fact download the tool and put it onto your desktop, of which I did, and you can in fact put in the results. Now if we put Peter's results in and we end up with compounding it, he ends up with 19%. That's a 1 in 5 chance of having a heart attack or stroke in 5 years. So suddenly someone who's systolic 135, I wouldn't treat that. He's got a cholesterol of 6, I wouldn't treat that. Well, one, it doesn't reach the PBS guidelines. And the other one is his HDL's all right and he hasn't got diabetes. So you see this guy slipped through the net and what happened? He died. And that's the issue of actually what's the missed opportunities that we had. So that's really what the idea of actually putting these risks together and compounding them together to come up with the score. So if we actually got him to stop smoking completely, he's dropped down to 1 in 10. Just simply by stopping the smoking, that's a solid risk to there, but he's still moderate. A moderate risk, so we're not letting this guy go when we use a calculator like this. Now, this is a major shift in the way that we in fact assess and manage cardiovascular disease. And it's generating some degree of resistance in the general practice and primary care setting because we're asking you to think about things in a different way. And we're also asking you to think about how we would actually grade and what we'll actually do with people on certain levels. Once we've graded them, it's also looking at a stepped-up management process of what we're actually going to do to people from those who are at low risk through to those who are at high risk. So how do we actually establish this profile? And the most important part about this is, do the guidelines apply? And is the person immediately high risk? And people who are immediate high risk are those who should be managed according to their clinical condition. So anyone who has established kidney impairment, anyone who has diabetes, these are the type of people who are already moving into the immediate risks. So once you've established that someone needs to do this and you need to go through the guidelines, you are going to need, before you start doing a cardiovascular risk, you need to work out the kidney function. So that's a albumin-creatinine ratio. You also need to work out the diabetes, so that's blood sugar. And you need to know those parameters that go in the calculator: age, sex, smoking status, systolic blood pressure, total cholesterol, high density, and left ventricular. That's an option to add it in. Other factors you need to consider but aren't in the calculator, such as atrial fibrillation, which we all know increases your risk of stroke quite astronomical, particularly the older you get. So immediate high risk, and this is really the ones that will save you the work when you look at implementing this in your practice. These people are already high risk. You don't need to do a calculation on them. You need to be managing their diseases. And that will in fact actually reduce their risks overall. The question when you look at your data set in your practice is, can I actually search my data set and find these patients? Are they actually there, the results in the right places and things like this? So that's the first sort of thing you should start to think about. Can I clear these ones out? And then I know that when I'm going to do absolute risk in my practice, I've already cut the workload down, because that's the important part. Now this is one of the most perplexing questions, as I was talking about before, about what's the difference. So a doctor who trained in the late 70s, early 80s was taught that hypertension needs to be treated, and we're treating on a relative risk thing. Someone with a blood pressure this high, they need to be this low, and that's what we're doing, and that's the intent. Once we've got the blood pressure there, that's fantastic. Surveys by the Heart Foundation have found that 45% of people with treated hypertension don't know hypertension causes heart attacks. That's fantastic, isn't it? They've got no idea why they're taking the pills for high blood pressure. They're taking them because they've got to get their blood pressure under control. They don't actually know what it does to them. Those sort of figures are what drives us as the foundation to say we've got a lot of education that needs to happen, both to practitioners but also to patients as well, at where they fit. Now, absolute risk is an idea of working out what is the actual chance of you having an event in a future of a defined period. It's putting together the risks and accumulating these things together to in fact create a profile. As the scales will show you here, put them all together and the scales drop right down, whereas relative risk is a comparison between one particular factor, like I said with blood pressure, or one particular therapy. I'm treating hypertension, what agent should I use? And that's when you start to use relative risk. Will I use a calcium channel blocker, or will I use an ACE inhibitor? Will I use two? When do I put on my second agent? What are the advantages of actually getting someone down to a target level? That's the difference, as opposed to a population tool such as absolute risk of the likelihood that an event will happen to you. The limitations, and this has come from the New Zealand data, and they've got nearly 300,000 in their data set now, so we're going to see a lot of stuff coming out of New Zealand to tell us why we should be doing this. So watch this space for where it is. The individual risk factors, if we only look at a couple of these, if we look at one, we're not in fact actually dealing with all, but if we actually add them all together, we start to get a profile of the risk increases as we compound. One risk factor, just a high triglyceride, add another one, and then suddenly you find, oh, this person who we thought was okay, putting all the other risk factors in fact actually has a higher risk. We do annual surveys of GPs, and thanks to anyone who's actually done one of those, and most, that is, 1 in 4, we call that most, or optimistic, say they're doing absolute risk. However, when we asked the second question meshed in the questionnaire, and you've got to forget this when you leave, so if you happen to get the questionnaire and you want to answer this, only 5% are using a tool. We know you can't do this without a tool. So we've got Joe, 64-year-old smoker without diabetes or known cardiovascular disease. His blood pressure systolic 136, total cholesterol 5.4, HDL of 1. Now Jane is 46, non-smoker, no diabetes, no cardiovascular disease. Blood pressure 142 systolic, total cholesterol 6.5, HDL of 1.4. Is anyone going to do anything to Joe? And what would you do? There's the calculator results. This one's even lower than your prediction. You were trying to do it, might be 10 or less than 10%. Again, that's pretty good. Okay, so 21% on that side there. This guy's high risk. He's got a 1 in 5 chance of having a heart attack or stroke in 5 years. That's going to make your lifestyle advice have a hell of a lot more impact, isn't it, when you tell him, do you want to have a stroke? One of the things that most Australians fear the most of is a stroke. For some reason they don't fear heart attacks because they think they're going to die instantly, which we all know as practitioners they're not. But the stroke part of this is that worried look on their face. You mean I'm going to be paralysed? So in answer to who are we going to treat, is anyone going to change their mind? This is what I talk about, this being challenging you on what you do and what you've been taught and what you've done to now. This is why the evidence is trying to do this, and to a large degree this is why you might be saying, I don't know, I'm a bit sceptical of this. But Joe, of course, is a challenge. You know, if most of us would say, let's get him to stop smoking, and if he maintains that, get him to come back and we'll do it again, and you know that will have dropped down. It'll still be moderate, because we saw that with Peter's example. So those are sort of things that you may consider about, where you'd go. But our guidelines say, Joe, you'd treat, Jane, you wouldn't, and then you'd set them on a review. But they both get lifestyle. How would I take, I've already learned a bit now, how am I going to do this at home? What am I going to do tomorrow when I walk into my surgery and work it out? So calculating the score and working out what in fact you're actually going to do. As I mentioned, our calculator is on the web, and you're allowed to download that as many times as you like. You're allowed to do with it how you see fit. And really you need to know age, sex, smoking status, systolic blood pressure, total cholesterol, HDL, diabetes status, and left ventricular hypertrophy if you know it. And these can be collected over a number of visits. Most people think, oh, should I do this at this visit? The answer is no. You've been doing a lot of these things as bits and pieces over subsequent visits, and it may be that you've already got all the information you need to do this, and you just need to do a desktop audit of certain patient subsets. So I always talk about absolute risk being a process, not a single event. You can use these pretty coloured tables, which most of you have probably seen for a number of years. The College of GPs sent these through. These were in the Red Book. These have been certainly sent around by a number of other pharmaceutical companies and the like, and you may have seen the New Zealand ones that came through. They're very, very similar to ours. And what you'll notice are those, they split already with diabetes, without diabetes, and then you look for the pretty colours. And The greener you are, the better you are, the redder you are, the worse you are. And patients respond very well to this, but they'll also respond very well if you do a comparison with the IT version that's on the desktop. You can do a comparison across the two. So stratifying those risks, as we mentioned, what are the differences? And low is anything less than 10%, moderate 10 to 15%, and high greater than 15%. There's a number of ways to explain high risk to patients to motivate them. The easiest way that I worked this out was Australia's a nation of betting people. And you say to them, if you knew the horse in the race was odds of 5 to 1, would you put your money on it? The answer is yes. Well, what I'm telling you today, at high risk, you're that horse. You're going to win the race that you don't want to win, and that is heart attack or stroke. You're a 5 to 1 odds-on favourite for winning a race you don't want to win. That is, if there were 5 people exactly like you in this room today, one of you will have a heart attack or stroke in 5 years. Do you want it to be you? So the intensity of what you're actually doing when you're targeting the results that you get. As I mentioned before, everybody gets lifestyle advice. It's a matter of how graded that lifestyle advice is and how urgent that advice is. The next part is, in fact, treatment on particular areas. With those in the moderate area, you make decisions on the individual risk factors of cholesterol or blood pressure, whether you will start medications or not in that area. And the immediate ones is pretty simple. And we made that on research-based evidence. You start the treatment. That's it. And we're going to get your risk down. A number of you have been involved in system change. Some of you may have done process work in your practice as to how do I do things. I generally ask people now, I've given you a lot of information and you're starting to digest a lot of this stuff, and you'll have a lot of questions to ask about some of the facts a little later. But the other thing is, how would you in fact actually do this in your practice? Is anyone actually starting to think about how might I do this? So step number 1 is data. And how many of you are comfortable that the data set that you've got in your practice, the clinical data set, is good enough to stand up to a search? Who else is in your practice that can actually help you get things done? Silence is deafening. Who is the most important person in your practice? The front face, exactly. Now, your receptionist is the most important because a couple of things. They are the face of your practice. They answer the phone for you. They are exposing you to medico-legal risk. Oh, I need a doctor's appointment. I've just got a bit of a chop bone stuck in my gullet. I'd started this morning and I'm a bit breathless. Doctor hasn't got any appointments today. We can give you one in 3 weeks' time. Yeah, that sounds good, doesn't it? The Heart Foundation's already thought of that. We've got training for receptionists and others for, in fact, identifying the warning signs of a heart attack. That's a 000 call. Okay, so not only is your receptionist, in fact, your front line for medico-legal defence, they are also an untapped resource. And I use my receptionists to the nth degree. I trained them to the nth degree. They were trained in mental health first aid, they were trained in triage, they were trained in streamlining patients, and they were actually in charge of the appointment book, not me. I said, you keep booking them in, and if I'm here at midnight, you will be too. Your choice. There are so many Australians in the high-risk category that are not getting any treatment that we really need to find them and deal with those before we start to worry too much about those that are in the low category. Until we've actually know that we've identified all those at high risk and we're moving their risk cycles down, we've got this enormous unmet need and potential disaster that's sitting there waiting for us with regards to Australians. As I pointed out in that initial data set, an awful lot of Australians have risk and a lot of them don't know it, and a lot of them are ticking bombs. It's a very busy slide, but you've got these in your handouts. And what I've circled here in the big bold square, and these are 2 here. One we have for Aboriginal and Torres Strait Islanders, 35 years and over, and the other is for other Australians over 45. The important part there, without a known history of cardiovascular disease. If you have already had a heart attack or stroke or have evidence of vascular disease such as peripheral vascular disease, you are secondary prevention. So you should be on a secondary prevention management plan. And that's a different guideline, and our guidelines on the Heart Foundation website talk about secondary prevention as to where that stands. So if you pass that first gauntlet and the automatic high risk, which is in that box, you can follow the algorithm down to actually what you'll do when you get a calculated result. And at the bottom of that, it'll talk about how often am I actually reviewing those cases. So lifestyle advice, following dietary guidelines. One of the greatest challenges that we in fact actually have with all of our patients is once they've left the room, we wonder how much they've actually taken in. And one of the principal parts of change management with patients is obviously the motivation cycle, and most of us have been trained in tobacco cessation, and we understand the stations of change that a patient may be in for motivational interventions, the pre-contemplators, the contemplators, and those that are actively in change. The power that you have as a GP and as a GP clinic in suggesting change is immense. It's the most valuable advice that you can give. There's no harm in suggesting about the dietary and dietary guidelines. Most of you would know the dietary guidelines unless you've been sleeping under a rock. Cut your salt down, cut your saturated fats down, and the other easy message, cut your total energy down. Total energy is much easier than starting to go into that perplexing, controversial area of sugar, because total energy, it consists of sugar and fats, so it's a lot easier. If you cut your total energy down, what's going to happen to you? You'll ultimately lose weight. So that's our goal. So referring to lifestyle management programs, that's where the problem begins. How many of you actually know where there are lifestyle management programs in your area? Show of hands, if you know of any. We've got no hands. So if you were to refer for lifestyle management, Heart Moves, okay. Top of the class. That's Heart Moves is a strength training program. So like all other strength training programs, it works on, in particular, core muscle strength. So more the larger groups, which has an evidence base to it. In fact, decreases hospital readmission for lung disease and heart failure. Also, by participating in those things, creates something on other muscles, which anyone who does these types of strength programs will tell you the most important muscles, these ones. What happens at the end of any of these strength training classes is very happy people. It's extremely good for mental health, extremely good for community connectedness, and extremely good for adherence to treatment, because other people in the room are happy and they're doing the right things too, because they all want to stay well. This is why you need to know where are your lifestyle programs, where are and how reliable are they? Because again, one of the most important things is that anything's up, say through a Medicare local directory or any other directory, is it valid? Is it sensible? I mean, you know, there's a whole lot of nonsense out there, and you want to make sure your patients are going to get the best chance to do something. And it doesn't really matter what the name of it is. It's a matter of actually, has anyone actually had a look at this? Has someone with any semblance of understanding about exercise physiology? Is it run, in fact, by people who are certified trainers? Is it safe? So these are the whole range of things like that. So medication. Medication, we really will cover the idea of safe prescribing, lipid lowering, blood pressure lowering, treatment of people with diabetes and kidney disease, the targets, and what sort of reviews we're going to do in adherence will focus. So if we're looking at lipid lowering therapy, the issue is we have to consider secondary causes for an elevated cholesterol and looking for those. One of the commonest ones is renal impairment. And I just told you that most people with renal impairment don't know because we don't test, we don't look for it. This is going to be one of those things as the population ages, we're going to have to look more and more for, but we want to find this at younger ages if possible. The other important thing to look at is what in fact is the benefit of putting this on. 74 doesn't seem very old to me, but it's also a question of how long are we putting someone on medication to achieve what benefit and for what. So that's again where clinical acumen comes in for you to in fact actually decide, do I or don't I start, and is there a benefit in starting someone on a medication at this age? And I'll leave that for you. First line therapy are statins, and if there's an inadequate reduction in LDL, you add one of these three agents here to try to in fact actually lower that. And if they're intolerant to statins, you really look at number 4. If they have raised triglycerides, you also have these three agents that you can look at for lowering those, and each of those has an evidence base behind them for decreasing the triglycerides. Blood pressure lowering therapy, again looking for secondary causes, and sadly undetected renal disease is another one. So you see, if you've got a systematic approach, you're looking at for cardiovascular disease, you've already done a renal screen. So you actually have ruled out the renal cause. Again, with age, looking at and thinking about the benefits of those in the aged group populations. In my practice alone, I'm particularly alarmed by 85-year-olds who are still in the community as to do they or don't they need this, how much of this agent. These are very, very powerful drugs. ACE inhibitors were invented in the time of my time being a doctor. I remember the initial trials on a drug called captopril, and that was used in the hospitals, and we were using these things, like we were walking on eggshells, because they are very, very powerful drugs that we tend to use very freely and tend to forget that they can in fact have quite profound changes on particularly the old population. So seriously consider, do I or don't I? Start with one of the following: an ACE, angiotensin receptor blocker, calcium blocker, or low-dose thiazide or thiazide-like diuretic. Treatment targets. Now, these targets were agonised over when the guidelines came through, so more than 800 specialists reviewed these guidelines before the NHMRC endorsed them. Now, you're allowed to, in fact, question a lot of these guidelines and ask why and how, but it was an extremely rigorous process because these are NHMRC endorsed guidelines, and to reach that rigorous process, they have to go through a very solid approval process. So the blood pressure targets is less than 140/90 for adults without CVD, 130/80 for those with micro or macro albuminuria, and 130/80 for diabetics. The lipid lowering, again, if you've been reading some of the literature, you would find that the US has taken away the idea of using lipid targets. Now, there's reasons why they've done that, but in the case in Australia, we have lipid targets, and these are the NHMRC endorsed and supported targets for lipid lowering. So at this stage, until they're changed on that area, the advice we give you is that this is what you're striving for and the reasons for doing that. Now, we mentioned the idea of adherence to medication, and 12 weekly intervals with lipid lowering until you're reaching target, blood pressure with 6 weekly until stable and targets, and more frequent if required. So the reason we screen for cardiovascular disease is to try to look for a healthy old age. That's what we're trying to look for. So the take-home message is, yes, you've got a very good reason to screen for the commonest reasons that Australians will get sick and die, and to try to make sure that they in fact actually have a healthy as possible old age.